And we're almost there. Hey everyone, and welcome to Chef AJ Live. I'm your host, Chef AJ, and this is where I introduce you to amazing people like you who are doing great things in the world that I think you should know about. I am so excited to meet today's guest. He not only has an amazing YouTube channel with over 1 million viewers. You have to check it out. I'll put a link below in the show notes. But he's actually a plant-based doctor who is in the trenches working. He's quadruple board certified. He's certified in internal medicine, pulmonary medicine, critical care, and sleep medicine. So I guess he would call him a quadruple threat. I'm surprised he's not certified in lifestyle medicine. Maybe that'll be his next venture. He's here today to talk about nutrition as medicine for COVID-19. Please welcome Dr. Roger Seheult. It is so great to meet you.
Well, thank you so much, Chef AJ. It's a pleasure to be on. I've been looking forward to this.
I can, 1 million subscribers is pretty amazing. So congratulations.
Thank you so much.
You know, and the thing is it's not just that you have 1 million subscribers, is that like you got those numbers in what, like a year?
Well, you know, we started back in 2012 as an education channel. And then when coronavirus hit last year, we went from about 400,000 to about 1 million in about a year. So about 600,000 people in about a year. Yeah.
And the content is fantastic. I love it. It's just a wonderful channel.
Thank you so much.
Yeah. So, you know, it's funny that you're quadruple board certified because I told you before the show that my doctor, when I lived in LA, had the same 4 specialties. And right now his boards are due and like they're all due at the same time. And he's going crazy studying that. That's pretty ambitious to be board certified in 4 different.
Well, yeah, they make us do it every 10 years. It's interesting that his are all sort of coming due at the same time. But if you want to be a pulmonary and critical care specialist and do sleep medicine, there's really no other way to do it because internal medicine is the basis, and then you have to subspecialize at every point along the way. So it's not like I'm an overachiever. This is just what I have to do.
Even though, have you ever thought about getting another discipline, lifestyle medicine? Because in a way, being plant-based, you sort of are interested in it.
I hadn't thought about it until recently, but I have been thinking about it. And the interesting thing about this, Chef AJ, is that the guy who started lifestyle medicine is a gentleman by the name of Dr. John Kelly, who is a classmate of mine from medical school. And he was interesting when we started. There was a bunch of us in the class. We were all about 20-year-olds, 21-year-olds, and he was 40. He had like 4 kids. And he now he's got to be at least in his 70s at this point, 60s, 70s, and he's going strong. And he's still working on lifestyle medicine and very active in the field.
You know, I've been trying to get him on the show. He was referred by Dr. Hans Diehl. That's a great story that he was a classmate of yours. Yeah, because I know they have the conference coming up and you can take the boards and. You know, even when did you become plant-based and become interested in that? And do you use that at all with your patients?
Well, you know, I didn't start out being completely vegetarian or vegan. By the way, that reminds me, my parents are watching, so shout out to my mom and dad. They're in Loma Linda. But when I went to school, I went here locally in Southern California to the University of California, Riverside, where I'm still actually on faculty at the School of Medicine. I remember at lunchtime going to the local Carl's Jr. and getting a burger. You know, everything sort of is convenience there. I think after we all, as a family, started to decide that we needed to start cutting this stuff out, and as the evidence started to pour in, and we started looking more and more at how a non-vegetarian, non-vegan lifestyle has its consequences and how we could actually do things in our lives to change that. And also the fact of growing up for me here in Southern California, very close to what we call a blue zone, and just living that lifestyle and being next to other people that live that lifestyle, we started to be more conscious of those things. And slowly these changes started to happen. It wasn't overnight. It was a very conscious move in a very specific direction. And that's how it became. So by the time I was in medical school and going through residency, pretty much had cut out a lot of those things.
That's fantastic. Do you feel better eating this?
Oh yeah, I mean it's hard to say because once you go through medical school and residency, that's like that has its other health consequences. So being on call 36 hours straight, but yeah, I think I would have done a lot worse if I hadn't made those changes.
Does your family eat this way?
Do they still eat that way?
Yeah, and I don't know if you have kids or a wife, but
Oh
does
yeah, absolutely. Yes. The kids are, yes, we all raised them all vegetarian. My wife, who was not raised as a vegetarian or vegan, also adopted this. She's also a physician as well. She's an internist. And that's important because I'm not the one that's in the kitchen. She's the one. So unless the one making the food is on your side, it's going to be a difficult task.
Absolutely. I was listening to every podcast I could find with you in it, and you told a really wonderful story about how she was the better student.
She was. You've listened very well. She was the one that sort of spurred me on to do better because, why can't I do that? That was a lot of it. And then it was sort of a competition in college that sort of, it was a cat and mouse type of thing. It was fun. It was all about the hunt. So it was good.
Yeah. I'm sure COVID affected all medicine, but, especially because you're critical care and pulmonary, did you ever expect anything like this? I mean, did anything you learned in medical school could have prepared you for this pandemic?
Not at all. No, I mean, in medical school, they teach you the fundamentals, they teach you basics. Residency gets you practical information, practical knowledge. When the pandemic came, it was almost surreal. I had to sort of take a 30,000 foot level and wonder if this was the reason why I had been called to this area of specialty, because literally everything was coming down and everything was focusing on intensive care treatment in the intensive care unit and hospitalists. My wife is a hospitalist. So, we had anesthesiologists that were really just waiting for surgeries, surgeons that were out of because the operating rooms were closed, ophthalmologists who weren't doing, basically everybody was waiting for things to happen because things had shut down, and we couldn't catch a break in the intensive care unit. It was one patient after another, and for a while there, we didn't know when it was going to stop.
Wow. Thank you for your service. Seriously, that's amazing.
Well, I can tell you, we were working with a team there. So obviously nurses who have been the backbone of the support here in the United States and around the world for that. Sometimes, they're trained to take care of 2 patients at once. They were taking care, in some cases, 3, sometimes even 4 patients at the same time. They were putting 2 patients in the same room. And so the experiences of nurses have been well described. Probably the unsung heroes, though, are the respiratory therapists. Everyone sort of forgets about them, but these are the men and women out there who, if those patients can't breathe, and a lot of them couldn't, they're the ones that are increasing the oxygen, checking the oxygen, making sure that we know when to switch them over a different form of oxygen or even intubate them. In some cases, like in my hospital, they were the ones that were putting tubes into the patients. And we were running real short on those. And as the ventilators kept doubling and doubling, the amount of respiratory therapists were the same. So those really were the unsung heroes of the pandemic.
Wow, thank you for pointing that out. You might not know this. Well, why would you? You were just meeting, but my first job in my 20s after graduating college I was a respiratory therapist.
Wow. Okay.
I cannot, I thought about that. Wow, I would be overwhelmed. I'm a very sensitive, kind of anxious person. I don't think I would have handled it very well, having to do that job in this day and age.
Yeah.
Wow.
That's impressive. You have a health background.
I do. Well, everybody in my family's a doctor. I didn't want to actually do that, but I do appreciate your work. So you're going to talk about nutrition as medicine for COVID. Nutrition could almost be medicine for almost every disease in a way.
It is actually. And there was some great presentations that I've been to. I actually got the idea for the title from a physician that works in Ohio called Lindy Schwartz. She gave a presentation at a conference back in Illinois called Food as Medicine. And it was an amazing presentation that I watched, where a lot of the myths were debunked in her presentation. For instance, one of the myths that was debunked was that carbohydrates are bad, that you should never have patients with diabetes eating carbohydrates. And really what I learned from that presentation, and of course there's many other things that we can learn, is that carbohydrates is not a simple one-size-fits-all category. There are simple carbohydrates and there are complex carbohydrates. And it's really how those carbohydrates are released and coupled and put together, it really has a big difference on the effect on the human body. Wow.
Well, it's true. What part of nutrition is medicine would you like to talk about first?
Yeah, so yeah, let's talk about that. There's been a lot of information that has come across, and sort of just to give you a span of understanding as we used to look at this, there was a number of studies, and you have to realize that when you talk about dietary and health medicine, it's very difficult to do the kind of gold standard studies that we're used to doing for pharmaceutical companies, and that is the randomized placebo-controlled trial. That's where you divide the group in, you give one group one thing, you give the other group something that they think they may or may not be getting, it's a placebo, and then you watch them prospectively. Okay, you can't do that very well with diet and nutrition because people have their preferences about what they want to do. So the way that we look at diet and lifestyle in terms of studies is something called a prospective observational study. And you try to pack them in with as many patients as you can and look at them for as long as you can. And in this country and around the world, when we've looked at those kind of studies, the same kind of signal was popping up over and over again. And that is that a meat-based diet and particularly processed meats were associated with an increased risk for ischemic cardiac disease. That means heart attacks, and ischemic cerebrovascular accidents. And the word that we use there is basically strokes. But in addition to that, we also saw an increase in cancer. We saw an increase in all sorts of cancer, colon cancer, throat cancer, liver cancer, breast cancer, all of these sorts of things. And a lot of the retort from those studies have been, well, look, these are observational, there's confounders, they could be associative, and we're not really seeing it associated with meat. It's processed meat. So we really need to cut down on processed meats. And that's really where we were in the last few decades until just last month. And that's why it's important that we're talking about this. Because one of the studies that's just come out that I really like to talk about is an interesting study that's come out of something called the Biobank in the UK. In the UK, they have a bank where they basically, a bank of patients where they look, and it's one of the advantages actually with socialized medicine is you can do very easy studies quickly because it's all standardized. But about 500,000 patients were studied way back in the late 2000s, and they followed them for about 8 years. And what they found was that not just processed meats, but just red meat in general increased the risk for ischemic heart disease, cerebrovascular accidents, ischemic cardiovascular accidents, basically strokes. But here's the part that they had never seen before. They saw that there was a statistically significant increase in pneumonia. Never has that been on the radar before, but pneumonia levels went up. Pneumonia is when you get infection in the lung. It's known as the old man's friend. That's what they used to call it, because it would put these old men to sleep. They would die from pneumonia and put them out of their misery. In addition to that, they'd also saw an increased risk of diverticular disease, colon polyps, and diabetes. So not just in processed meats, but also in just everyday regular meat. So how much meat did it take in this study to be associated at this kind of level? It was meat 3 times a week. That's not a lot. If you consider the amount of meat that some people take, it's served almost at every serving when they sit down. In the morning, it's sausage. At lunchtime, it's a deli meat. And in the evening, maybe it's a steak. And they think that unless they have that, they're not getting their full requirement. Just 3 times a week was associated with up to a 44% increase in pneumonia in these patients. And we're now just starting to understand the pathophysiology. There is an explanation that I'd like to propose as to why we're starting to see. Why is it? What is it about protein from meat or meat itself that's different than plant-based diet that causes us to have an increase in all of these very bad things? There is a theory.
So why are they feeding meat to patients in hospitals?
Yeah, that's a good question. Well, there's a couple of reasons why that could be. Number one is I was going to say you would be surprised, but maybe you're not surprised how much reimbursement to hospitals is coupled to customer service and customer reviews. So if they don't have those things, then they're not going to get very high on the rating. In addition to that, the surveyors that come around that survey the hospitals and look at them are also going to be looking at the kind of things that they have in their diet. And these are regulated by Medicare, who pays a lot of the bills to the hospital. And of course, the things that they are drawing on are the federal standards. And of course, the federal standards say, what do they say? They say, not don't eat meat at all. They say meat in moderation. Okay. So, so if you take something that has a problem with it, you will say, that's bad. We should only do it in moderation. So if I found like arsenic or poison, it should only be taken in moderation. I'm being a little facetious there, but the other aspect of this too, that's a little bit more serious, a little bit more on the serious side, is you probably don't want to impact someone's dietary habits right in the middle of an illness and add a little bit more stress to them. So get them through that point, get them to an outpatient type of situation, and then work on a long-term plan in terms of diet. And you know, I'll just put my 2 cents in here. My preference would not be to go from 0 to 60 in 2 seconds and take somebody who's eating meat or red meat 3 times a day to basically going completely vegan. And you probably would agree. You want to look at the most egregious things and start making those changes definitive and irreversible changes, but slow changes so that the body can adjust.
It's just, this blows my mind that it's because of ratings they have to do this. It's just, wouldn't it be cool if there was like a hospital that was just plant-based?
Yes, well, I know there's a number of outpatient residency programs that deal with grief and depression, and they deal with health. One of those places that I was privileged to actually visit, and I know that you know about it as well, is New Start up there at Weimar Institute, soon to be hopefully Weimar University here very shortly. They've just been accredited. And I was able to sample some of their food, and I'll tell you, it's incredible what they do up there.
Right. Well, I mean, it's been a long time since I visited Loma Linda Hospital. It wasn't vegan, but it was, if I remember, vegetarian, the cafeteria.
That is correct. So if you are not a patient, but you're visiting there, you will not find any meat products in the cafeteria. But I believe the patients, and I believe it's because of federal regulations that they have to feed their patients, or they have to at least give them the opportunity if they want to have meat. But yes, many an afternoon after medical school was spent in that cafeteria.
Wow. Got a lot of people watching live. I don't know what your parents' names are to see if they've commented, but Marilyn says, great to see Dr. Seheult. Listen to him frequently. Great information. JL says, please tell him I love his channel. I've been listening to as many of his videos as I can. His advice about the COVID vaccine helped me make an informed decision to get vaccinated.
Great. Yes. Well, it's Carl and Ingrid. So if they're not big commenters, but they're definitely avid watchers.
That's fantastic. Do you want to touch on the elephant in the room? No matter which side you take, you're going to offend somebody, right? If they don't agree with you, but you're an actual not just a medical doctor, but you're a frontline in the trenches, COVID treating medical doctor that has seen this since it began. And so I really respect what you have to say about, vaccines and masks.
Yeah. So, okay, we can talk about vaccines and masks. Yes, no problem. So I will start off by saying that you've got to sort of see it from my point of view about where I've come from on this. When I was working very hard, 5 weeks in a row, 12-hour shifts, dealing with horror stories that you could not believe, where patients are on ventilators and dying, and we're trying to reach their loved ones, and they're down in the emergency room and being admitted at the same time, and whole families are getting wiped out except for 1 or 2 people. Certainly, we're seeing the worst of the worst. And so when people asked me last year, Dr. Seheult, are you going to get vaccinated? I said, whoa, I haven't seen the data yet. I haven't seen the side effects yet. When that comes out, we're going to have to make a decision. So I was surprised to see that the Pfizer vaccine was as effective as they said it was, greater than 90%. Moderna also greater than 90%. And so when it came out in late December, because of the fact that I was in a high risk group, I was seeing patients with COVID every single day. They were being intubated. There was aerosolization. I had, family at home. My mother-in-law is living with us. My folks, of course, are not too far away. I certainly said to myself, look, if there is a substantial risk to this, there's a potential great benefit in my situation because I'm at high risk for bringing a deadly virus home, number one. Number two, and I don't want to ever live. I would rather something happen to me in terms of the risk of a vaccine than have to live with the fact that I passed this on to somebody, or at least I didn't do everything that was in my power not to pass it off to somebody. So in the end, because of the fact that there was very little in terms of published side effects, and because the efficacy was so good, that I went ahead and got the vaccine in late December, and then the second shot was in January. And I've been fine, haven't had any issues. My wife also got the vaccination as well. So how do we look at this? Look, so these natural remedies that we like to employ, of rest, exercise, having a good immune system, eating well, these are all very good things. And none of those things in any way, shape, or form, in my mind, is negated by taking a vaccine or not taking a vaccine. So because I might talk about a vaccine doesn't mean that I have no belief that these things are very beneficial. But let's face it, there are some things in this life that even the best diet, even the best exercise, sleep, all the things that you can do to give you the advantage, there's some things that won't take care of. If you get into a car accident, the medical institution needs to be able to take care of you at a trauma center. Even those people that are very well, they're vegan. I know of people in my church that have been vegetarian or vegan their entire life, and they come down with colon cancer. So what this does, lifestyle helps to sway in one direction or another. And I think if there's no other issues, I think that's the best thing that we can do. On the other hand, in the middle of a pandemic, when there is a virus that can infect somebody, and even somebody in their best health lifestyle situation can become infected and can pass that infection on to somebody else, there is something to be said for that extra thing that we can do to not only protect ourselves, but protect other people from getting a potentially deadly virus. It has to go down with not us as individuals, but us as a community. So for instance, if you can say that, look, if there's a less than 1% chance of coming down with or dying with the coronavirus, why should I take the vaccine? Well, the reality is that you may have a 1% chance of dying, but it's not like the virus is either going to kill you or let you go free. It can cause long-term morbidity. There's a recent study that came out showing that up to a third of people who have had the virus can have psychiatric or neurological problems. And so there are other reasons why, even though you might not die from the virus, you may not want to get the virus. I know of people that for no other reason decided to get the vaccine because they didn't want to lose their sense of smell. And some people, even a year later, have not completely gotten their sense of smell back. So there's a lot of morbidity and things that are associated with this. If you look at the data, the Pfizer, BioNTech, the Moderna, and the Johnson & Johnson vaccines, they have gone through rigorous studies. The technology for this type of vaccine goes back to the 1990s when they first started to do messenger RNA in animal cells, and they've been working on this technology. They're actually, Moderna, before the pandemic, was working on medications from messenger RNA to actually produce medications for people with autoimmune conditions and things of that nature. They immediately switched to studying vaccines, and they were able to get this vaccine out very quickly because of the data that came out of China in terms of the sequencing of the spike protein. The data looks very promising. It's very effective. And in terms of the side effects, and I know that's a big concern for many people, how fast this came out and the side effects of the vaccine, you've got to put it in perspective. So in this country, in the United States, let's look at the numbers. There's been about 180 million doses of the vaccine that have been given out. And certainly enough, there have been some anaphylactic reactions, some allergic reactions, things of that nature. And if you were to total it up, it would reach maybe about 1,000 or 2,000 of those here in the United States out of 180 million. Certainly, there's been some deaths that have occurred after the vaccination. It's unclear whether or not they were a result of the vaccination. They're trying to still figure that out. According to the CDC, they have investigated every single one of these, and they have not come up yet with one of these that have been a result of it. So if you look at those numbers, now let's look at something very different in the United States. Let's look at drivers. Every single day, about 115 million people get into cars and drive. And of those people, every single day, you may not realize this, but every single day, about 16,000 people get into car accidents, whether it's a fender bender or whether it's a head-on collision. And every day, about 100 people die of automobile accidents in the United States. Every day, 100 people die because they get into a car and they drive. So if you put those two things next to each other, we understand that the automobile companies make a profit. We understand that the automobile companies sometimes cause fraud. Sometimes they get sued. Sometimes they have to pay out millions of dollars. We know that people die from getting into cars, but yet we make a conscious decision that the benefits of going into a car and using it to do something outweighs the risk. And we're putting our lives, our bodies, into these cars and driving them. And so we have to weigh the same risks and benefits when we're talking about a vaccine, except with a vaccine can actually prevent other people from becoming injured. And so you can see that if you were to drive, I've made this analogy, if you were to drive to a vaccination site, that the vaccine that you would get there actually currently has a better safety record than the vehicle that you would use to get into the car to drive to the vaccination center. So just be careful. There's a very big denominator of millions and millions of people. And so when the media plays out on these numerators of things that you see, you've got to look at the whole thing in context. And that's kind of a long and short of my opinion on vaccination.
Right. So the thing that concerns me, and again, like we said before, come on, I am not against or for. I'm against people's right. I'm for people's right to choose. So if somebody doesn't want to get vaccinated, I respect that. And if they want to, I'm against vaccine and mask shaming. I don't like the people that are mean to one other group because they have a different opinion. But one of my concerns is, other than I am a medically sensitive, highly allergic patient who has had really bad, to a flu shot and a pneumonia shot, and, really, really severe. I'm allergic to aspirin. I'm allergic to NSAIDs. I'm allergic to most antibiotics. So I'm really scared. My sister who got it did end up in the ER. And I do know somebody that died from it. So my thinking is, since I don't have a job like you, I'm willing I can do my job at home. I have been sheltering, so I feel like I'm not going to get it or give it. But I guess my main concern is, how do we know that down the road something won't happen from it? Because it was rushed to market, like you say. Usually it takes years for these clinical trials. And how do we know, like, we won't get Alzheimer's or something as a result of having it? Do you understand what I'm saying?
Absolutely. So a couple of things. All of the corners that had to be turned in the process of getting the emergency use authorization were not cut. So the data, so they did the animal testing first, and then they went to the human testing as well. And then that human tested went from phase 1 to phase 2, and then to phase 3. And all of that data was presented in summary to the FDA. The FDA, all the people on the FDA committee, we knew their names. We knew exactly what they were coming from, how they voted, all of the concerns that they raised, whether they said yes or whether they said no. And so all of the check boxes were done. Yes, it was speeded up tremendously because there was a tremendous amount of resources that were poured into it. And there was a tremendous amount of will, kind of like in World War II, we took over Ford Motor Company's factory to make tanks and planes. But it's not like those planes and tanks fell apart because they were rushed to market. They still did the job. And so we went through all of the process. The question is a good one, though. How do we know that there isn't going to be some deleterious effect of the vaccine down the line? A lot of potential issues has been something called antibody dependent enhancement. This is where if you have a vaccine and you make antibodies against the virus, then when you actually get the infection then causes a worse disease in the patient. And so these phase 3 trials were specifically designed to make sure they would be able to detect and pick up if there was something called antibody dependent enhancement. And that did not happen at all in the studies. There was less hospitalizations, there were less illnesses, there were less deaths in those that got vaccinated. But again, that's immediately. How do we know something down the line isn't going to happen? We know that in the history of all vaccines, and there's been 59, 60 different types of vaccines that have been approved, that there are some vaccines that do have problems down the line. The one that comes to mind is the flu vaccine that was released back in 2009 in Europe that caused an increased risk of narcolepsy. So that happened within 6 weeks of vaccination. They saw that there was a problem within 6 weeks. In fact, all of the problems that have happened long-term from vaccines have occurred in a very short 2 to 3 month period. Now we're into the 4th month. So while it's possible, if it does happen, it would be the first time we've ever seen that.
Yeah, I'm such a naturally worried, kind of anxious person, because I keep thinking about a medical decision I made in my 30s, which was to have radial keratotomy, which was considered the gold standard at the time. And now they're like, the doctors are saying it was horrible, it was barbaric, we shouldn't have done it. And so I'm having problems now 30 years later that can't really be fixed. And so my mind is like, well, you know what I mean? This is how I make a decision.
Of course, yeah.
But again, that's why I don't want to shame people from it. Everybody should it's their body. They should be able to make their own decision without people, berating them one way or the other. But we do have a few people like Alyssa asking, is the vaccine actually vegan? And I guess what she means is what you're getting. Because to me, as a 44-year ethical vegan, the fact that it's tested on monkeys, it's just, that's another problem I have with it. It's like, as an ethical vegan, how do I live my life this way for 44 years? And then all of a sudden I was like, well, take a vaccine. When I saw these monkeys and how it just bothers me.
Well, yeah, I mean, it probably would be impossible for most medications for you to take any kind of medications if you didn't want to have one that wasn't tested on animals. There was some criticism, false criticism, that these vaccines were not tested on animals and that they were immediately tested on humans. And there was criticism on that. That actually wasn't the case. They were tested on animals first. And so that's what happens when you do these vaccines. You want to make sure that you're not testing on people that, first of all, are complicated. One of those types of people are pregnant women. So they were specifically excluded from the study because there's complications there. You don't want to risk 2 people as opposed to just 1. And also you're wanting to try these trials out initially on monkeys, which is what they did before they tried the human trials. So yeah. It's a good question. There's a difference between testing and then what's in it. So is there anything from animals in the vaccine itself? I'm not aware that that's the case. There's what's very unique about this vaccine, as opposed to flu vaccines in the past that people have had issues with, is preservatives, is mercury, aluminum, these sorts of things. None of those preservatives whatsoever are in the mRNA vaccines, the Moderna or the Pfizer vaccine. Now, in the Chinese vaccine called Sinovac, which is CoronaVac, it's basically a killed coronavirus. They do put a little bit of aluminum in there to cause an adjuvant reaction and stimulate the immune system, but that's not available here in the United States.
Is there any iodine in it? I'm actually allergic to iodine too.
I don't believe there's any iodine in there at all. There's the PEG, or the polyethylene glycol, is the carrier that allows the lipid bubbles, if you will, to merge with the cells and deliver the messenger RNA.
Great. Renee says, is this an actual vaccine or is it gene manipulation?
It's definitely not gene manipulation. Messenger RNA is a code that goes into the outer portion of the cell called the cytosol. It never goes into the nucleus, which is where the genes are. And by the way, the genes are written in the language of DNA, not in the transcript of RNA. So unless you have some sort of an enzyme to put RNA into DNA, which doesn't exist in the human body, you're not going to get gene manipulation. The other reason why you wouldn't get gene manipulation is because the shot goes into the arm and infects the cells just in the arm to make those proteins. And as soon as they start making those proteins, the immune system destroys those cells. That's why you get pain at the site, is because those cells are being destroyed by your immune system. And those are the only cells that get infected. So it goes nowhere else in the body. It goes, all of your DNA and your genes everywhere else in your body stay intact. Even the cells here, they never change their genome. Only the messenger RNA gets expressed in the outer portion of the cells and they get killed.
Thank you. So a couple of people like Jackie are saying, can you talk about the ivermectin protocol?
Sure. So ivermectin is an anti-parasitic medication that was initially identified early on in the pandemic as a potential for a therapeutic, and very similar to hydroxychloroquine. There's actually a couple of different mechanisms that were proposed. One was that it prevented the proteins from going into the nucleus of the cell. Another one was that it prevented the binding of the virus to the cell. So there was a number of different mechanisms that were proposed. There was also some randomized controlled trials, some of them not controlled, some of them randomized, some of them not randomized, around the world, especially in Argentina, Brazil, Iraq, Iran. These papers were compiled and published, and it showed that there was amazing differences in the trial groups versus the placebo groups in terms of patients that were admitted to the hospital with COVID-19. So these were assessed and looked at, and there were many different physicians, individual groups that were using ivermectin. And then Dr. Pierre Corey, who addressed the Senate committee, probably 2 or 3 months ago now, was compiling and showing that there was a lot of these studies. If you look at the studies, and I took a look at these, and I'm obviously anything that works, I'm all for. What we like to see in medicine is a randomized, placebo-controlled study that is peer-reviewed and published in a population where it's being proposed to be used. So unfortunately, we haven't had a randomized placebo-controlled trial here in the United States. I know they're planning one in Pennsylvania. The issues have been that we haven't been able to reproduce these randomized controlled trials here in the United States compared to what they were doing in the world. I used ivermectin in our hospital. We gave it all the time to patients, and I didn't see this miraculous improvement. But nevertheless, medicine is complex, and so we used it. The issue is that ivermectin is an anti-parasitic medication. Okay, that's first and foremost. If you look at the populations in these countries where these randomized controlled trials have been done, you will see anywhere up to a 50 or 60% prevalence of chronic parasitic infections in patients. So these patients walk around, they're asymptomatic, but they have parasites. And it's a battle between the immune system and the parasite, and they're kept in check because of the immune system. So what happens is they come down with COVID-19, they go to the hospital, and one of the standards of care in the hospital is high-dose steroids called dexamethasone, and that is to prevent the cytokine storm. So what happens is you give Decadron, which suppresses the immune system, and now what happens is the concomitant parasitic infection is now allowed to expand. And so it doesn't surprise me that in these populations, the addition of ivermectin is going to improve survival in these patients who have a lot of parasitic infections. I don't know if that's the reason why we're seeing it, but it's certainly an explanation, because when we do the trials here in the United States, and there was recently a trial that was just published in JAMA that showed that there was no difference in COVID-19 patients with or without ivermectin. And it may be because we don't have as high a concentration of patients with parasitic infections. So notwithstanding that negative study, I still think more research needs to go into this. Unfortunately, you need a lot of patients with COVID-19 to do those kind of studies, and we're kind of going down, except for a few places right now like Michigan and Colorado, New York, New Jersey, and Pennsylvania and Florida. So again, to the degree that we can do more studies, I think more studies are required.
Thank you. Just because you read something doesn't mean it's true, but I read that the people that are having more side effects from the vaccines are actually healthier people, and the ones that are like sick with comorbidities seem to sail through the vaccines. Is there any truth to that?
Well, the reactions primarily from the vaccine are coming from your innate immune system. And to the degree that you have a very robust innate immune system, which is very important in terms of fighting the virus, yes, people who have more comorbidities may have a weaker innate immune system and therefore not as much of a reaction.
That's very interesting. So thankfully you can't see what I'm seeing in the chat, and I've already warned people if they're not respectful, boom, I got a little button, I send them away. So as hot topic of vaccines is, there's another one that's, and especially you see this not just in the, got more questions coming in, but this topic of masks. And there's some people that I know and respect that are really against masks and say they don't work. And I mean, that's another hot topic.
Yeah. So the fundamental truth of it is that COVID-19 spreads through two different mechanisms. There is large droplet, which comes out of the air very quickly and settles on the ground. And then there's aerosolization. And once you understand that there's two mechanisms of how it spreads, you'll understand why we get the results that we get. So first of all, what is the mask very good at? The mask has holes in it that are much larger than the viral particles. And so you could look at that and say, there's no purpose for wearing a mask because it doesn't stop the virus from going in and out. Well, there's a couple of caveats that you have to understand there, is that the virus is generally concentrated in large droplets that come out of your mouth. And the masks are very effective at stopping those large droplets, which contain the viral particles in suspension. So in terms of direct, large droplet spread of the virus from person to person that are within 6 feet, masks are actually 99.9% effective at completely putting the kibosh on spreading things that way. But if you're in a room with very little ventilation, and you're still wearing a mask, you and I know that even if you're wearing a mask and somebody is smoking in the room, you're going to smell that tobacco smoke before very long. And it's because the particles that we're talking about are so small, they become aerosolized in the room and they suspend, and they can suspend because they're very small for hours and hours and hours. And even though you're wearing a mask, you're going to be breathing that in. The mask is not going to prevent that aerosolization of those viral particles. And so in those kind of situations, it's critical to have ventilation in the room. It's critical to have aeration in the room. You know, if you look at what went on in New York in the subways, there was massive amounts of contagion and spread of the virus based on the subways. People were touching things. People were in a very closed environment. They may or may not have been wearing masks. A lot of them were wearing masks, and yet the virus was spreading for that particular reason. Contrast that with airplanes. So on an airplane, it's mandated that you wear a mask. That's very helpful in preventing you from spreading to the person sitting next to you. But in a very closed environment, somebody at the front of the plane who's breathing for 6 hours coronavirus out of their mouth is eventually going to build up in the cabin and can potentially infect everybody on that plane. It doesn't happen because on the plane, they have very high levels of ventilation and filtration. All of the air gets circulated around many, many times. It's gone through a HEPA filter, and the air that comes back on the top part is 50% mixed with outside air. So the air coming out of that is pure air, number one, and it's blowing away any viruses that might be coming onto you. And if you look at the data, you'll see that there's been very few outbreaks associated with airline travel. Very few outbreaks associated with airline travel. So the fact of the matter is that masks do work in terms of stopping the spread that they're designed to stop, which is basically large droplet sputum going from one person to another.
Why do you think the people that are so against masks are against them? Because most of the ones that are not actually medical doctors. There are a few that are, but most of them are not.
Well, it's an invasion of privacy. Look, when I go to the hospital, when I would go to the hospital and take care of COVID-19 patients, I had to go to the hospital. I had to wear an N95 mask at 7 o'clock in the morning, and I had to put a regular mask over that N95 mask. Whenever I would go into a patient room and come back out, I'd have to take off that mask, switch it with another one. That mask would not come off of me until 7 p.m. that night. I tell you, it wasn't very comfortable. I didn't like to wear it. It wasn't fun. but my oxygen levels were fine. My carbon dioxide levels were fine. I felt like I could breathe better. I didn't have to put as much effort into breathing through a very rigid N95 mask. But let's face it, look at surgeons. For years and years and years, surgeons have had to wear masks in the operating room for up to 6, 7, 8 hours at a time. Some of these operations go for up to 10 hours. And we haven't noticed any decrease in vitality or increased risk of anything in surgeons. And despite that, despite the fact that surgeons had to wear masks, we didn't say, we're done, we don't need to do anything else. No, we also had to institute positive pressure ventilation in these operating rooms to make sure that diseases went out of the room and not got sucked in. But we also had to sterilize the equipment. So this idea of, if distancing works, why do we have to do masks? And if shutting things down works, then why do we have to wear masks? And we don't look at it that way in medicine. We look at all of the potential things that can go wrong. And if we have layer after layer after layer, it's much more efficient at shutting things down. And so early on in the pandemic, I didn't have a problem with wearing masks because I had to do it in the hospital all the time. But to somebody who's not familiar with the medical field and they have to walk around with a mask, I can see how that might be a change to them and might be less agreeable.
Right, but they say they don't work. And how do they know that?
I don't know how they say that it doesn't work because we have the study. I guess it just depends on what you want to see. If you go to the internet and type in masks work 99.9, you will see all the studies that have been published that show that masks work.
Yeah. Thank you. So you've seen a lot of patients with COVID. Have you noticed a difference in the ones that have it really bad versus milder cases and recovered, such as things like age, comorbidities? What can you tell us?
Yeah, so you can pretty much predict who is not going to do well from a COVID standpoint. People that are older, people that have diabetes, people that have kidney disease, people that have coronary disease. At first, when it first broke, we thought that people with lung disease and asthma would be the ones that would be filling our intensive care units. In actuality, that's not the case. We didn't see that much more in terms of the population that had asthma and COPD. It was much more coronary disease and the kidneys. And I think the reason for that was because of the high prevalence of blood clots that are being caused by people with COVID-19. They did a study that was published in the New England Journal of Medicine where they did autopsies on these patients. And they found, in comparison to regular lungs on autopsy, the lungs of COVID-19 patients had 9 times more blood clots in their lungs. And these blood clots are not just limited to the lungs. These blood clots go to the brain and can cause this brain fog of COVID-19. They go to the kidneys and they cause them to have to go on dialysis. They go all over the body. And that's been, I think, the real problem with a lot of this virus, something that other viruses don't do, that this virus is very good at doing, unfortunately, and that's causing blood clots to form.
That's interesting. Have you seen anybody that's like a really healthy long-term vegan get COVID?
That's very interesting that you say that. We don't take a very good dietary history when patients come into the emergency room. But the good news is that we're starting to look at that. There's a study in Great Britain. They're looking at people with COVID-19 and they're looking at what their dietary and lifestyle habits are to see if there's a correlation to that. Me personally, I have not seen anybody who was a vegan with a very good diet that had gotten COVID-19, although there have been people that I would say are relatively thin that have come down with COVID-19. We had a lady, unfortunately, in her 30s who had just miscarried and got a very severe case of COVID-19 and actually passed as a result.
Sorry.
So we have seen people that you would not normally think as being at risk for hospitalization coming into the hospital.
Wow, thank you. People that have already had it, do they need to get vaccinated?
Good question. So one of the things that is sometimes thought of is that a natural infection gives better immunity than a vaccine, right? Because it's a natural infection. It's the body doing its natural thing. We have many, many examples where natural immunity is not as good as the immunity that a vaccine could give. And the example, of course, is HPV. Human papillomavirus is a virus that infects the cervix and can cause multiple infections and then eventually can cause cervical cancer. The vaccine for HPV can actually completely stop with 99.9% efficacy cervical cancer. So there's an example there where a vaccine is far more efficacious than a natural infection. As it turns out, we don't have to look at these other viruses. We can look specifically at COVID-19. And there's a immunologist down at La Jolla in San Diego called Shane Crotty, who has looked at this. And the data that's coming out is very interesting. If you were to take everybody that had been infected with COVID-19 and measured their immune response to it, it wouldn't be that, some are, 100%, some are 80%, some are 50%. There's actually a 100-fold difference between the person who got the least immunity and the person who got the most immunity. So there's a very wide range of immunity, probably because there's also a wide range of dosage that they got in terms of the virus. And so because of that issue, we sometimes see people who have been infected with the virus, who turn negative, who go home, and then they come back in again and get readmitted again with another viral infection, another COVID viral infection. And so because of that, and because of the fact that it's very difficult to assess without doing very advanced testing how immune somebody is to the COVID-19, it's not just antibodies, it's also T cells, et cetera. And because they wanted to get shots in the arms of people as fast as possible to stop the spread of the disease, they made the decision to say, look, we're not going to make a distinction of people who have come down with COVID-19, whether or not they should get the vaccine or not. We only say, and this is what they had been saying up to this point, to wait 90 days between the end of their infection and getting the vaccine.
Thank you. Linda says, do you think that COVID-19 started in the Chinese wet markets?
It's certainly possible. There was, nobody knows for sure. And I think it's one of the possible things. Obviously, another possibility is that it was a virus in a level 4 lab that escaped. I mean, that's a possibility too. They institute measures there to prevent that sort of thing from happening. But there was a but at the very beginning of the pandemic, NPR did a really nice story where they went in to where they said they may have come from bats. Well, they went to this area of China where there's a lot of bats in caves, and the locals go in there and get the bat guano, basically the bat poop, if you will, because it's very good fertilizer. And when you go down into these caves and you're with the bats, this is where the viruses jump. They jump into human beings. So when they sampled these humans that were living in the area to see if they had been infected with these viruses, they found that there was all sorts of coronaviruses that live in these bats that had gotten into these humans, but it hadn't made the jump to go from human to human as yet. And so it doesn't seem like a far cry to say that this pandemic may have come from a human being that got a virus from a bat, either by going into the cave or the bat flying by or going to a wet market. We see that this is not unusual, but we see this in Ebola. The reason why Ebola keeps rearing its head every few years in West Africa is because of the dietary habits of the people that inhabit that area by eating the bush meat, which is where the Ebola virus hangs out. And so that seems to be the formula for how these viruses get out into public. So it's certainly possible.
Yeah. Here's a funny comment. Well, not funny, but ironic, from Carrie's, who said, people have said to me, I won't get the vaccine because it's poison. Then they go to McDonald's and order nuggets and fries.
Yeah, and it's the same thing. I mean, people say, I don't want to get the virus. I'm sorry, I don't want to get the vaccine because it comes from a very dishonest company that has paid out millions and millions of dollars in claims and criminal claims and things of that nature. And I think that for Pfizer, it was like $2.9 billion. Well, if you look at VW paid out $9 billion in things. And VW is not unique. There's other auto companies as well. And so, if you want to hold the same bar there, you've got to be careful, because if you hold that bar for vaccines, then you've also got to hold that bar for, automobiles. And so I assume that you're walking around everywhere and not driving. So you've got to be realistic.
Yeah, thank you. So JL says, can you please ask him about pregnant women getting the vaccine? My daughter is pregnant, has underlying health conditions, a BMI of 41, high blood pressure, high blood sugar, etc.
Well, that's an excellent question. So let me preliminarily get some data here. Well, I don't have the data right in front of me, but I can tell you this. It's very interesting. When they did the phase 3 trials on the Pfizer, Moderna, AstraZeneca, and the Johnson & Johnson vaccine, they explicitly wanted to exclude pregnant women from those trials. But they had women who could get pregnant in those trials, and a certain amount of them did get pregnant during those trials. And so they were able to track these women who had gotten the vaccine and track them for a number of things. Number one, did they get pregnant? And number two, were they able to take the pregnancy to completion? So what they found was that in all of these studies, there was equal number of people in the trial and in the placebo group. And if you look at all of those trials, there was the same number of people who got pregnant in the vaccinated group versus in the placebo group. There was the same number of people, generally speaking, who could not carry the pregnancy to term, in other words, a spontaneous abortion, a miscarriage, in both groups. So there was really no difference at all. But and the other thing I would mention too is what we did notice is that women who were pregnant, who got COVID-19, okay, COVID-19's effect on the pregnancy was not very good. In other words, they were more likely to end up in the intensive care unit. They were more likely to get on a ventilator. And so if you look at those, I would say that if you are pregnant, based on the data that we have, that it would be recommended to prevent those bad effects to get the vaccination. Now, if you want more up-to-date information, there's an authority that I follow to find out about this, and her name is Dr. Victoria Mail. She is a reproductive immunologist that works at the Imperial College in London, and she has a Twitter feed that you can follow, and she gives you all of the up-to-date statistics and information. She updates it on a regular basis. So if there's any questions about that, I would follow Dr. Victoria Mail. She's a world expert on this.
Thank you. Anita is saying, what is the risk of taking the first vaccine but not the second?
Good question. So the risk is not getting the full benefit. You know, when we do things, you know what happens if you buy something. It says on there that if you take the cover off or manipulate this, then the warranty is void. And the reason why they say that is because they can't guarantee that it's going to work as it's supposed to. It's the same thing with the vaccines. The vaccines were designed, they were submitted to the FDA as a 2-dose vaccine. And so they don't know what's going to happen from the data if you only take one of those. Now, that being said, there's been recent data that has been released and was published last week on the CDC website that looked at first responders and nurses who got the Pfizer, BioNTech, and the Moderna vaccines, mostly in Arizona, but there was some others as well. What they found was that the number one, that the vaccines were greater than 90% effective, greater than 90% effective after the second dose at preventing infection, not just hospitalization, but actually becoming even infected. After the first dose, they found that the efficacy was 80%, which is not that bad when you consider it. But again, going from 80% to 90% means that you're reducing the infection risk by 50%, because you're going from an infection risk of 20% down to 10%. So in my estimation and in my recommendation, get the second dose.
Great, thank you. So there's a question from Christine. Is it true that high doses of vitamin D make you less likely to get COVID?
We don't know that getting high doses of vitamin D would make you less likely. What we do know is that high or normal vitamin D levels are associated with less risk of COVID-19, of the SARS-CoV-2. Now, that sounds like the same way of saying the same thing, but the key here is that association does not necessarily mean causation. And that's been the issue with vitamin D for a long time. We've noticed that if you were to look at the United States, they did this study with 190,000 people. And they found that whether it was male or female, living in the North, living in the South, black or white, it didn't matter. That as your vitamin D levels went down, particularly less than 50 nanomoles per milliliter, that the rate of SARS-CoV-2 infection went up, that the rate of hospitalization goes up, that the rate of mortality goes up. And so we don't know if something is causing the vitamin D levels to go down is also causing you to be more susceptible, or whether it's the vitamin D levels specifically that's causing this to happen. The thing I would mention, just recently, they did a study that showed that people who spend more time in the sun have a lower risk of dying from COVID-19. And this study was done in places of the planet that you can't really get enough vitamin D from the sun. And so they felt, the authors of this study felt that somehow outside of the mechanism of vitamin D, sunlight was improving the outcomes of SARS-CoV-2 without the vitamin D component. And I think that's astounding. And it tells me that we ought to be spending more time in the sun.
Well, that is good news for this girl who lives near Palm Springs, because I'm in the sun about 2 hours a day. I don't let it on my face, but it goes everywhere else.
Yep.
I'm excited. So there's a few people that are asking that if you get the vaccine, can you still get COVID and or still be a carrier?
If you get the vaccine, can you still be a carrier? So that's one of the things that we learned from this study out of Arizona, was that the vaccine, so when the drug companies submitted the data to the FDA, it was specifically and purely only a reduction in the recipient, a reduction in the disease in the recipient. They did not check in those phase 3 trials for a reduction in infection. And it was given emergency use authorization based on that. Now we have independent data, not from the drug companies, that's showing that these vaccines not only reduce disease in the recipients, but it also prevents, like a wall, infection, and therefore the transmission of asymptomatic virus to somebody else, which is exactly what we were looking for in terms of herd immunity. That's exactly the type of thing that we need.
Great, thanks. So we had people write in questions in advance, and this one from Amy is, she listens to your YouTube and she loves it, and she learns so much from the evidence-backed science that you share. She says, what are the potential risks for the current vaccines causing an immune response mismatch against future variants? Can getting a targeted vaccine like the ones currently available cause our immune system to potentially have a poor immune response because a future variant is sufficiently different and the antibodies we are programmed to produce would be ineffective? Are any drug companies working on broad spectrum vaccines that attack coronaviruses as a whole instead of just specific spike proteins? That's a very specific question.
Yeah, so that's a very good question. So if we were to develop antibodies against things other than the spike protein, there is the danger of running into something called antibody dependent enhancement. That means where it's what we call a non-neutralizing antibody, where the antibody binds to the virus and then doesn't stop it. It still allows it to infect and then sometimes enhances it. So you want to only have antibodies against the protein that prevents it from binding to where it needs to. And I think the first part of the question gets to the point was, if the spike protein mutates in such a way, will the antibody not be able to bind and escape the neutralizing ability? And that's exactly what the concern is with these variants. Make no mistake about it, variants happen all the time. As soon as the virus enters the human body and starts to reproduce, it makes so many mistakes that it's making variants all the time. Those variants that are not equipped for survival die and never make it on. But the ones that find the loopholes, the ones that find the gaps in our immune system are the ones that are produced, and those are the ones that emerge. And we've noticed that there are 3 or 4 major variants of concern here in the world, and that is the South African, the Brazilian, and in some respects the UK, although that one seems to be pretty tame. The 2 major concerns is the Brazilian and the South African. Now, there's been a lot of press coverage about how well do the current vaccines neutralize those variants. Where in terms of generality, where we have seen slippage in terms of the ability to neutralize is the ability to stop infection and to stop mild disease. Where we have not seen a problem is the antibodies and the vaccine's ability to stop severe disease. So what do I mean by that? The Johnson & Johnson vaccine, for instance, was tried out in South Africa, where the South African variant is the highest. And there it was around 66 or so percent in terms of efficacy. But if you look at the data, up to 49 days after that shot was given, the amount of hospitalizations and deaths were zero as a result of people after they took that vaccine. So the vaccine, even though there's some slippage from the variants, are still very good at giving the body the head start that it needs to prevent death and hospitalization.
Yep. I'd like to see a vaccine to inoculate people against being judgmental and disrespectful, if you could come up with one, because there's a lot of people watching that could actually benefit from that. All right. So here's an interesting question from Lori, who's watching live. My son had a kidney transplant 3 years ago. He had his vaccine, and 2 weeks after the second one had an antibody test, which came back negative. It's as if he didn't vaccinate. Is this normal?
That's very interesting that you say that, because just today, there's been some data that has been released now where they've looked at people who are either taking monoclonal antibodies because of a disease, or they are immunosuppressed on steroids. And it's not surprising what you've mentioned to me, because what they're saying here is that in some cases, the antibody response from the vaccine is on an order of tenfold different. Sometimes tenfold lower than what you would normally expect to see. And so that is the concern that we're seeing with people who are immunocompromised, who are taking immunocompromised medications because they have to, because of their conditions, that the vaccine may not be as effective as what we'd like to see. Realize that what we're measuring here are antibodies. Antibodies are the product of B cells. And B cells are only 50% of the equation when it comes to immunity, because there are T cells as well. And we haven't done the studies yet to see how they react. So these are in vitro surrogate markers that aren't giving us the whole picture. But the picture that we are seeing is that, yes, there is a reduction in those neutralizing antibodies.
Thank you. Pam says, I'd like to know if Dr. Seheult can tell me if taking prednisone during the vaccine process is unsafe. She was given to it by her orthopedic doctor for a broken arm.
Yeah, and so that goes along with what we've just been talking about, is that it can affect the body's ability, at least acutely, to make the correct antibody response. Now, it may make that up later on, but yes, even non-steroidal anti-inflammatories have been counseled against in terms of taking before you get the vaccine.
Great. Well, hallelujah. We have a question that is not about masks, vaccines, or COVID. And okay. I do want to respect your time, because you are quadruple board certified, and maybe we'll have you back to talk about sleep, because that is such a fascinating subject, sleep medicine. But Lynn wrote in saying, I have always needed a lot of sleep, sometimes up to 12 hours. I sleep pretty well at night. Consistent 9 p.m. to 6 a.m. and can easily take a 2-hour nap around 3 to 4, which helps me gain energy through the rest of my day. I've had my thyroid checked. Standard test came back negative. Doctor said I probably just need more sleep. She's loves the whole food plant-based diet, mostly SOS free, doing it 6 to 7 months, but still tired. Thoughts on what to test for? I have very low vitamin D. I just wish I had more energy to go on the whole day. Would somebody like that benefit from a sleep specialist? Maybe have a sleep test or something like that?
Absolutely. So what she has there is hypersomnia, and she has what we call a long excessive sleep hours, although that distinction has been kind of done away with in the diagnostic, but that's kind of a detail. What I would start asking her just off the bat would be things like, do you have any signs or symptoms of obstructive sleep apnea? That can certainly give people the sense that they have excessive sleepiness and need to sleep a long time because they're not getting the quality sleep that they need. So one of the first things that I would do is to do a very simple test, either a home sleep test or an in-house polysomnography, to see whether or not she has obstructive sleep apnea or she has symptoms of that. And if that were the case, that I would treat that first before even going on. If she didn't have any other signs or symptoms and was negative for obstructive sleep apnea, I think the next step that I would do is do a very interesting test where we have them sleep the whole night in the sleep lab, watching them very carefully, again, making sure that there's no obstructive sleep apnea. And then the next day, we would have them do multiple naps where we would see if they could stay awake for a long period of time, for more than 8 minutes. It sounds like a short period, but it's actually staying there for 8 minutes is kind of long. But with the very key of looking to see what kind of sleep they go into when they go to sleep. So some people normally when they go to sleep, they would go into a stage 1 sleep, a stage 2 sleep. But people who have excessive sleepiness could go into REM sleep. And if she went into REM sleep more than a couple of times, then I would be looking at some other diagnoses. Things that come to mind would be like narcolepsy or other diagnoses, depends on her age. But yeah, there's a lot of things that we could do to work that up.
When you get a sleep test in a lab, can you bring your dog? I can't sleep without a dog.
If it's a service dog, I think they can't prevent you from doing that. Although I'll look at those rules.
That's interesting.
Yeah.
Just because this is a very heavy subject, COVID. So I'm trying to just lighten it up by asking you something fun.
Sure.
Were you able to ever influence any colleagues? Just forgetting about COVID for a minute, just because of your diet being plant-based, did that spill over to any of your colleagues or patients or things like that over the years?
A lot of the colleagues that I work with are a vegetarian, and that's fortunate in that sense. What we do at in the ICU, whenever we have, like for instance, on Sundays at lunch, we sort of order out, and that's when I would, they would, hey, Dr. Seheult, what do you want on your pizza? And I'd say, please, light cheese, if any, and then olives, and they're getting the pepperoni and all the sorts of other things. So it's an interesting discussion that we have, and it's a way, because you as the physician in this case, you get a chance to sort of tell them what you do, and you're kind of looked up to because you're the head of the team, and so you get to sort of set out as an example. And there's always a few people that are interested. Most people aren't, because they have their certain dietary habits. But when they start asking about things, you start to tell them, and you already have this implicit trust with the nursing staff because they know that you're knowledgeable on this. And so when you start to talk about these things, you have a little bit of authority and you're taken seriously.
Right. So I think being a doctor has got to be pretty stressful even without COVID. And I used to volunteer at a hospital for years until the pandemic. We're not allowed. How can we support all you frontline workers? And thank you, because they won't let us in,
A lot of times we would walk in and there'd be signs that were made or cards that were made, and then we'd be delivered. Sometimes it would come in and they say, hey, there's like a whole thing of food there back there. Who's that from? Oh, that's from the Jones family in bed 2. They wanted to, and so those little things that just show that you're thinking about us really is what it is that we have to do. That really keeps us going. And comments like you just made, just letting us know that you're there, it makes it all the worthwhile. Just this last week, I saw a patient in our clinic that had been in the hospital for months on a ventilator and had been actually transferred out to an acute long-term care facility. And he came back and he was looking great. And, just seeing people that have gone through the process and survived is really, just sort of testimony to everybody's hard work and making it all worth the while.
Great. Well, I would look forward to the day of having you back where this is just, I don't want to say something we laugh about, but just, it's a whole different world, isn't it?
It is.
Well, thank you so much for being plant-based, for being awesome, for the work you do. If your parents are still on, I'm sure you must be very proud.
Well, thanks.
Yeah. Thank you so much. I really appreciate your time.
Yes. Look forward to coming back on, maybe talking about sleep and some other issues as well.
Absolutely. I find that just so fascinating, the whole sleep thing and sleep apnea. So interesting that so many people have it, even people that aren't overweight.
Yes. Yeah, absolutely.
Right. So thank you so much. And thanks all of you for watching another episode of Chef AJ Live. Please come back tomorrow, the regular time of 11 a.m. when my guest is Mary Matosian, who wrote a book called I Love Bacon, But I Love Me More. No bacon for us, right, Dr. Seheult?
No bacon.
Take care. Bye-bye.